It's wonderful to be here today talking to Dr. Robert Friedland, who's a very eminent neurologist, teacher, researcher from the University of Louisville, Kentucky, where he is a professor and chair. And we're going to discuss today his book, recently published, 99 Lessons in Critical Thinking, which I think is an invaluable resource for people working in medicine across different disciplines, especially doctors. Thank you for doing this, Rob. Wonderful to have you here.
Thank you, Chris. Thank you.
Let me start by asking you this. You emphasize that clinical attention involves more than just listening. It's about identifying what truly matters in the patient's experience. How can clinicians train themselves to become attentive and to recognize and prioritize what's relevant for the patient?
The only way to do it is to have a conversation and to listen deeply so that you're not preparing to speak while the patient is talking. And that after you listen to the patient, you repeat back to them what you think you heard them say, or you might say to the patient, I see that you have this feeling or this reason why understand that you want to continue smoking because so-and-so. And the essence of communication is listening, and don't take things for granted based on what you think about the patient's social status or ethnicity or clothing. And all of this is a problem because doctors are more pressed now than ever to see patients quickly. And there's a danger that the omnipresent electronic health record will take precedence over your attention. So regardless of what's happening in the electronic health record, regardless of what some other doctor has to say, you need to be aware of what the patient is actually experiencing. And in the old days, we were trained to take a comprehensive history. And for example, a patient with pneumonia, it might be very important to know that they have 25 cats at home.
Yeah.
But I'm not suggesting you have to ask every patient, do you have any cats? But they have an infectious disease. Maybe that's not something that you might learn otherwise. And you'd only learn it if you ask about it. Similarly, I had a patient who's discussed in the book where she has some dizziness and balance problems, and she was 82 years old, and she wore shoes with a high heel. Not like this, but maybe like this. But still, I told her, I'm very sorry to say this, but at your age, you need to have your foot in as much contact with the ground as possible. So you can't wear those kind of shoes anymore. And of course, I wouldn't have said that if I hadn't noticed what kind of shoes she was wearing, even though it's not part of my neurological exam. Cranial nerves, motor, sensory, reflexes, coordination, and gait, and shoes is not part of it. But if you pay attention, you could notice. And there's no way around it. This takes time. And I would say that the patient interaction begins as soon as you see them in the waiting room. If you go out to get them in the waiting room, see how they're dressed and how they shake your hand and how they walk. So you can accomplish quite a bit there and you can establish their language capacity as you take a history.
In fact, I think the author of the Sherlock Holmes series, Arthur Conan Doyle, who was a physician, would do that. He would go to the waiting room and watch the patient walk in, and he knew where he was coming from. So if he had red mud caked on his shoes, he was coming from 5, and so on. So goes the legend. I learned something there. Thank you so much. To repeat to the patient what you think they just said. I don't think we do it often enough, that we are reaffirming what we thought we heard them say. So they get an opportunity to sort of correct us also if need be, isn't it?
Exactly. Thank you. And the other part of this is you have to try to understand the patient's situation in the context of their own life, so that if they're obviously, if they just suffered a loss in the family, they may have depression, and that might influence how they take their pills and how they're physically active or inactive, or why their blood pressure is going up. Another example, let's say a patient is late, and they have an appointment one day at 9. They show up at 11. Another time they have an appointment at 8:30 and they show up at 1. And you think they're just lazy or inattentive or unresponsive or irresponsible. But it could be that they live far away and they have to take public transportation, and the first bus from their house, doesn't leave until 9:30 or something like that. Or there could be something about the patient situation which explains it, and you won't learn that if you don't consider it.
Yes.
Or they may not take the medication you give them because they can't afford it. But maybe you're embarrassed to tell you this if you don't ask.
Talking both about clinical experience and intuition as being important, but you feel that sometimes they can mislead us if we rely on them too much. Would you like to elaborate on that?
You have to be willing to make rational judgments and to consider how you feel about it, and at least perhaps don't send them for radiotherapy just because your intuition suggests they have cancer or they look like but if they look like they have cancer, if they look really sick and you don't understand why, certainly considering that they could have an occult carcinoma is worth discussing. So your intuition may be guiding you in the wrong way or the right way, but you can consider in an informed opinion what the best way to pursue the answer is, considering your rational judgment and your intuition. So that I find meditation is helpful in that regard. It makes you more aware of what you're thinking about and where your mind is going.
And of course, all of us sort of rely on past experience quite a bit, and to a large extent that guides our intuition as well. Is there a practical way in which we can balance that with care, compassion, and being accurate in the work that we do?
Well, I think past experience is both very valuable and very dangerous, because no physician has a statistically appropriate random sample of the population. And if you tried a drug 3 times and it failed each time, that could be because it's a lousy drug or because 3% of the time it doesn't work, and that's responsible for these 3 cases. Another example is a very prominent Alzheimer's specialist. I know he's very knowledgeable, he's very opinionated, and he's always saying that he can tell who has Alzheimer's and who has vascular dementia and who has something else. And he has these criteria for this and these criteria for that. And it occurred to me that because he lives in a country where they never do autopsies, he has no idea what he's talking about. He never actually had a patient that he saw who died who had an autopsy, so he would know, was he right or not. So he's just making a judgment out of thin air, which is interesting, but not valid if he's never been able to verify it. And actually, nowadays, we practically never have an autopsy.
Yes.
Our patients who die. However, at the same time, I believe it's critical to pursue our clinical experience as much as possible, so that, particularly for young doctors. So my experience is, resident sees a patient in the emergency room, and the patient is admitted, let's say, to the surgery service. The next day, that resident, if he's on an emergency room rotation, he'll be back in the emergency room. Well, he or she should pursue the information, find out what happened to that person that he admitted to the surgery service the night before. Perhaps it turned out that patient died because he actually had something else that they didn't notice, or that he did have what they were suspecting. But at least if he or she goes to pursue and find out, he has an opportunity to learn. And my experience is that this never happens, or very rarely happens. But I describe this as a part of the idea of being fierce, of being aggressive in pursuit of your own information, of your own education. You have to go after it. You can't just wait for it to fall on you. Or the education is not the filling of a vessel. Education is the lighting of a fire. So I want the young doctors to be on fire in this regard.
But you were pointing out earlier that we also live in an era when we tend to be very reliant or very focused on the electronic medical record. Most young doctors have multiple responsibilities. Time is often in short supply. How does one balance this out?
It's quite difficult. All I could say is that they should pay attention to what's important. And they should pay attention to sleep, because it's not, as I mentioned earlier, everybody needs 8 hours. So if you can only get 4 hours of sleep because of your call schedule, your function will be impaired. So you should take that into account. If you have time, you need to get more sleep, and arrange your schedules so you can have as much sleep as possible. And spend your time doing important things, not watching the news or watching movies, although actually it is also important to relax, to find an opportunity to. You can't be working all the time or under pressure and be in stressful environments at all times. And take advantage of opportunities for learning. So I remember being in the elevator in a hospital building, and a very famous hematologist just happened to walk into the elevator. And I asked him a question about hematology, and he was upset that I had the nerve to ask him, since he didn't know me. I was a young doctor. And he walked away in a huff. And I mention this because this is uncommon, but it's worth doing this. This is exactly what young doctors should do. Ask questions, and then keep on asking questions. And the chance that people will be upset about your questions is very low. It's not zero, but so what? So this guy didn't like my question. He didn't think he had a responsibility to answer my question. So he's a SOB. Well, that's okay. But other times I've asked questions and found that even very famous, important persons in science and medicine will stop and answer my question, even though I was a medical student, or I was a resident or junior professor.
And what can institutions, hospitals, and medical schools do to foster this culture of critical thinking, learning, questioning?
Right. Well, I think one way is to challenge them and to not teach to the test. So the truth about the exams in America is they're really not hard. They're really designed to catch the bottom 5% maybe. And then, but it is true that your score on the test may influence how well you do for a residency. But the tests seem generally emphasize facts, not judgment or comprehension or awareness or capacity for paying attention to the patient. So that I think we should go back and have more case questions based on humans. So where there's the examiner and the person being tested and the patient who volunteers to be part of this. That way would be more effective than just being tested on facts. I would like the testing the teaching to be in constant awareness of history, because the mistakes of the past were made by people who were very smart. It wasn't the fact that they believed that the sun revolved around the earth. It wasn't because they were stupid. So history is filled with examples of judgment, good judgment and bad judgment, and we can learn from that. And young doctors can learn a lot from that. It's almost endless to understand the value of concepts in medicine based on history.
You've also said that intellectualization limits compassion. What guidance can you give young clinicians on how to stay emotionally connected while in the midst of very hard clinical, situations that they are trying to tackle?
The key word here and elsewhere is awareness. So be aware of how you feel and be aware of the fact that the situation may be painful and unpleasant, but you can't wall yourself off from it. You don't want to be sobbing together with the patient's wife, but you can allow yourself to understand how she feels and be there for them. Touching a shoulder, or I would sometimes grab the patient's, if the patient was lying in bed, I might hold their foot, and it might provide some solace. And the easiest way to interact with difficult situations like that is to be absent.
To be absent.
Absent. Just, well, maybe I won't see Mr. Jones today.
Mm-hmm.
Well, the other doctor will take care of this.
Right. Yes.
I mean, there's a horrible diagnosis. Well, I did my job. I ordered the CT scan. Now they're going to see the radiation oncologist. I don't need to see them again. And also, it's wrong to think that there's nothing you can do if you can't fix it. So a lot of doctors will be so turned off by the fact that they're impotent in this particular case. So they'd rather not be confronted, they'd rather not deal with it. And that, or they may think, I'm not going to go into the room because I don't know what to say. And they should all know that it's not necessary to say something. It's not necessary that you know what to say. Sometimes just being there is what they need.
You're so right. I think it's so easy to procrastinate. Going and meeting someone or following up with someone when the prognosis is poor, or the case is challenging, or they're just not getting better for whatever reason. Your enthusiasm to go and meet with them does wane, and it does result sometimes in you pushing it off a little bit. And of course, that's not the right thing to do. The patient needs us to walk with them every step of the way.
There is a similar to religions, that your responsibility is to be there. You don't have to know what to say. And sometimes all you can say is a shrug, like, or I don't know, just a shrug of your body and physical gesture. And the intellectualization comes from often, particularly, I think, in neurologists, they will talk about the phenomenology. They'll talk about what's happening, what is the patient demonstrating. And my example is my chair at Mount Sinai many years ago. We went to see a patient who had a new diagnosis of a brain tumor, and she was crying. And the professor left the room and said to the students, including me, in the hall, notice how she has emotional incontinence caused by the tumor in the frontal lobe. And that wasn't why she was crying, because she's a human being and she just was told she has a brain tumor. Yeah. He couldn't deal with that. So for him to leave the room when she started crying was wrong. For him to tell us that the phenomenon we were watching was caused by the brain disease rather than the humanity of this woman was also wrong.
You've spoken about the power of language and how questions are framed in clinical settings. Can you give us some examples of what appropriate and inappropriate ways of framing questions that we end up witnessing in clinical practice.
Thank you. My favorite example is the phrase rule out. If you rule something out, that means you've eliminated the possibility of its occurrence. But if a patient has a cough and you do a a chest X-ray, and it's normal, that doesn't rule out pneumonia, because it's still a low possibility, but it's still conceivable that there could be a false negative chest X-ray, and the patient has pneumonia even though you did a chest X-ray and it was normal. So to say that it's ruled out implies that you're now sure. So you don't need to think about it anymore. But that's not the case. So you can't rule out Alzheimer with an MRI scan. You can't, even a biopsy is capable of error. False negative biopsies happen all the time. Perhaps most current is Ukraine sank a big ship from Russia, and the Russians describe it as not floating properly. So the news said that the ship was not floating properly, but what they meant was that it had been sunk. But they didn't want to use the words, they didn't want to say that it was sunk, because that doesn't sound very good. But to say it's not floating properly was a euphemism. Elon Musk's space, one of his big ships, blew up, and they didn't say it blew up. They didn't say it blew up. They said it was suffering an unanticipated disassembly, which is kind of not exactly what happened.
Came apart. Yeah.
It came apart, right? And so this is just to show you that words impact how we think. And this is true very much in medicine, just as in any other area.
And doctors, therefore, should be very careful in their choice of words when they are interacting with patients and of course with one another.
Certainly. And similarly, we shouldn't think too much about the words neurology or psychiatry. I mean, where is the border between neurology and psychiatry? They really deal with the same thing. It's all about the brain, so that the disciplines are historical artifacts. They're meaningful, then we can't do away with them completely, but we should be aware that if I'm a neurologist and I have a patient with a psychiatric problem, I can't just say, oh, I'm going to send them to a psychiatrist. Perhaps I could do something, even though this problem was identified as psychiatric and I am identified as not psychiatric.
With increasing reliance on electronic medical record systems, people becoming data points, and a lot of digital in medicine and investigation in medicine, how do we retain sort of person-centered or patient-centered care?
One thing the doctor and student can do is appreciate the complexity of the medical record and make it clear what's happening. If you see a patient on a certain day, then when you write a note, make sure that it's not longer than necessary. Don't copy the previous note and paste it into your current note. Don't fill your report with erroneous or irrelevant material. So one neurosurgeon I know would copy every note and put it into the next note. So when you went to read his notes, you had no idea, no way to know what was happening.
Right.
And also, in general, to pay attention to the patient and not the note. So certainly, you can't have the patient over here and the computer over here with the doctor facing this way and not seeing the patient. I've been in this situation where I'm the patient and the doctor is not facing me, and he's talking to me, and I'm wondering, who's he talking to? He wouldn't know what, he wouldn't appreciate gesture, which is important part of language. So that the student or any kind of nurse practitioner, doctor, or whatever, should always be facing the patient and not facing the computer. It's best if it can work if the computer is to the side of the patient doctor and the doctor can look at the patient and the computer at the same time. But it shouldn't be a question of doing this like that while they move from thing to thing. And the tragedy is the electronic health record is designed to enhance billing. It's not designed to enhance patient care.
And at the best of times, it's also a kind of a defensive tool, isn't it? You're more preoccupied with making sure you have all the data points completed than necessarily the right impressions about the conversation that you're having.
That's right.
We often go into a sort of autopilot default in our thinking. And how do you sort of identify that that's what you're doing? Because when you see several patients a day or you have a busy clinic, there is this tendency to sort of perhaps operate at spinal level sometimes, or if not spinal thalamic level. What does one do?
I take time to get to know the patient as much as I can. So I want to know where they went, how far they went in school. I want to know what they actually did. Not only the name of their, like, let's say, accountant. I want to know what kind of accountant, who did they work for, where did they go to school. I want to know what they like to do when they're not working. So it's not enough to know that, well, the patient, I'm in the Navy, let's say. Well, you could be in the Navy and work in a nuclear submarine, or, to be honest, there are various. So in order to, I get to know the patient. If possible, I'll put that in my first sentence. So I might say, 49-year-old nuclear submarine engineer with a 6-month history of so-and-so and so on, which is progressive and affecting this and not affecting that and so on. So I personalize it to some degree. And awareness, of course, is always part of this. And my favorite example there would be a pediatrician could see 100 patients before they get one who has meningitis. And I don't know what the real frequency of that would be, but they need to consider the fact that every kid with a fever or with a headache, they need to be aware that some of them are sicker than others, and some of them could die if you send them home without any further care. So I don't know how they can not be put to sleep, so to speak, by the fact that they have so many kids with earache and nose infections and sore throat. And then all of a sudden you get one who has earache and nose infection and meningitis. So they have to be constantly aware of that.
What do you think are the sort of the most important barriers to critical thinking? What prevents us from engaging in critical thinking when we are in the midst of our clinical work?
Thank you. Somebody said, when we are young, we're judged by the quality of our answers. But when we grow up, we're judged by the quality of our questions. And this is true also in medicine, that I've had many teachers who really didn't like it when you asked them, well, why is this? Why is that? What's the cause of Parkinson's disease? Didn't I tell you they have alpha-synuclein deposits in the brain? Well, that's not the cause. That's part of it, but it's not. What's the cause of that? And if you go on like this, many teachers will not be happy. It's my own experience, even in school, that in elementary, high school, that my questions were not always answered, or not always welcomed. So this is quite critical, so that we need to learn to keep asking questions and never stop. And did I answer your question?
Yes, I think the importance of being questioning and the importance of asking why is perhaps something that one should not, or if you stop asking why, you're probably not going to be critical anymore.
And my favorite example there is, imagine an 80-year-old man who falls at home and breaks his hip. So he comes to the hospital and the orthopedist is going to repair it. But that's not enough. Somebody has to ask why he fell. Does he have osteoporosis? Is he unstable because of ear disease? Maybe he's not taking his medication. Maybe he has hypertension and that's why he fell. Or maybe he has a small dog who runs around like this all day long and he tripped over the dog. You send him home again, he's going to fall and break his hip again. Yeah. So, but who's responsible for that? I wouldn't be surprised if most surgeons or many surgeons are really very, very good and very focused on repairing the hip. And that's it. Thank you very much. Don't bother me anymore. I fixed it.
Thank you. We sort of multiple disciplines usually working with patients. So in a sense, we have doctors, nurses, paramedics, and we often work in silos because each group has its own priorities. How do you build a shared culture of critical thinking, sort of with a diverse group of healthcare professionals serving the same patient?
We need to be open to how they might contribute, and we need to be open to new ideas and to appreciate they're all biased by our experience, and need to be able to work together. However, that's very difficult nowadays with the complexity of scheduling. In Cleveland, we would see every patient. The second visit would always be a summary conference with a nurse, a doctor, and a social worker. And often the patient needed attention from the social worker more than they needed the doctor.
Absolutely. In fact, two examples I find in my own work. When I do hospital rounds, I often find it very useful to read the nursing records because they make note of things that the junior doctors don't necessarily think is extremely important to make note of because the priorities are a bit different. Here, the medical conditions recorded. There, various other things concerning the patient get recorded. So this is one lesson I've learned, to look at both notes, both sets of notes, to try and understand what's going on better. And we work as a multidisciplinary team. So we rehabilitate patients together. So our team has got physical therapists, psychologists, speech therapists, holistic physicians, neuromodulators who stimulate the brain, all working together on the same person, say with Parkinson's. What becomes very useful is when we sit together and talk about the patient. So we have these mid-therapy and end-of-therapy case conferences where we discuss the patient and his progress. And of course, each person comes at it from a different perspective. The psychologist has a completely different perspective on what they're looking at as important and what they consider as improvement. The physical therapist has a different perspective. The holistic physician thinks differently. So I find that sort of, as you were saying, the Cleveland example of getting together and talking about someone, very, very useful as a way of engendering a thought process or a discussion or critical thinking, as you call it.
That's excellent. And somewhere I need to say that a basic problem is that thinking is difficult. That it's much easier to do what we do and keep doing what we've already done and do what we've already done, do what we usually do. And that particularly in medicine now, the young doctors are learning to follow the algorithm. Okay, if it's this, it's that. If the test is this, you do that. And if the test is normal, you do this. If it's positive, you do that. But then you do this and this, and all the way down. So everything is answered. All your decisions are made for you, and you don't have to do any thinking. A good example are the new Alzheimer diagnostic tests. So it's quite complicated, but they may accurately determine what's going on in the brain, but that doesn't necessarily mean what's happening to the person.
Yeah.
So that the test would be misapplied, misunderstood, and miscommunicated.
And the focus on the person rather than just the data points.
Exactly, right. And exactly. And that, as you said, focus on the person. And I like that because you didn't say focus on the patient, because a patient is only somebody who's already got sick enough to be under your care. What about people in the community who are not patients but have hypertension and they don't know it, or they're smoking too much and they need to stop? So that I've struggled in our hospital to get rid of this decision. Our mission is to improve patient care, to have the best possible patient care. I would like rather they would be concerned with the care of persons, which include people who are not patients.
Preventive health.
And the problem there is we're not paid to take care of people who are not patients.
Yes. With the onset of AI, what do you think will happen to critical thinking? Do you think it will help us sharpen our critical thinking, or do you think in some ways it's going to stop us from thinking at all?
I think it might help, but I'm not optimistic. It could be replace critical thinking. And so I hope that in the future, there'll be a computer in the room with the doctor who will be listening to all the conversation. And the computer will have a camera focused on the patient. And if the patient is doing this throughout, the computer will suggest to the doctor that it might be a Parkinson tremor. And if the patient says, I was bitten by a dog and I have this pain in my hand and my arm is shaking and I can't swallow water, the computer would say, this sounds like rabies. So that the computer can do some analysis and that it would make suggestions. Hopefully it wouldn't take over, but I think it could improve. And there we must consider the fact that 50% of doctors are below average. So that we're concerned not only with the best care possible, but just avoiding below quality care, which is.
You froze there just for a moment.
Yes.
At least for me, yes. You emphasize that good science is not about being first, flashy, or even brilliant, but asking meaningful questions, using diverse methods, staying grounded in thoughtful design. A lot of people want to engage in research, especially in a country like mine, but they lack the time or the resources, or even, they feel the lack of formal training. How do we get over this barrier or these barriers?
I do believe even today that physicians can make contributions with case studies, even a single case report. And the history of science is that this has often proved to be very valuable. And it's often part of science to take advantage of discarded materials. So that, for example, tonsillectomies are very common. Otolaryngologists here do them, I don't know, hundreds every month. And the tissue is given to the lab where the pathologist says, it's a tonsil and it has some inflammation. It's not very interesting or important, but that tissue could be studied for research. How that could be, that's another matter, of course, but it is something that is commonly done, and the tissue is often neglected. Or who is, if you have a total knee replacement, somebody gets the knee that was removed. And I imagine it goes to the lab and they say, well, okay, there's arthritis in this knee. And then they throw it out. So there's a lot of tissue there for a cell biologist, biochemist, or immunologist could be studying. Are there any bacteria there in the joint? What kind of white blood cells are there? Are there natural killer cells participating in the arthritis, or what's the cause of the arthritis in this knee? Is it just trauma, or is it something else? And I'm not an orthopedist, so I can't say exactly what they want to do, but there could be something that could be done with material like that. And William Langston encountered some patients who were about 25 years old in Stanford in the 1970s. And they had sudden onset of Parkinson's disease caused by a toxin, which they didn't know they were ingesting. That started off as a case report and was one of the most important discoveries of neuroscience in the 20th century. But he just discovered this by going to the emergency room.
Yeah.
and that this kind of thing happens not infrequently.
So from case reports to getting involved in sort of studying things carefully, which may seem to be just ordinary, but they are available for study. There are many ways in which you're saying that people can get involved in research and can get involved in critical thinking. And that obviously helps develop the field of medical science.
Yes. A good place to start is An Introduction to Experimental Medicine by Claude Bernard, who's a great French philosopher, scientist. I think it was 1876, something like that. But the Dover Press has a English edition. It's like $8. So it's very beautifully written. And also, I would suggest young people interested in science can consider volunteering. So if you're in medical school or in college and there's a lab, you'd be surprised how many, if you offered to volunteer, they could say no, or they could say yes. So it's an opportunity, and it might be an opportunity, and you never know what things can lead to. Again, the history of science is filled with people who didn't know what they were doing, ended up in some lab, and ended up doing something turned out to be really, really, really important.
And path-breaking, yes. Thank you. I think that's been a really interesting conversation about the book 99 Lessons in Critical Thinking. And congratulations on publishing the book quite recently.
Thank you. Could I say another thing about it?
Of course.
I wrote this book because for the last 40 plus years, I've been teaching medical students about neurology. But the setting is that I would have, let's say 30 students would come, I would have them for 1 hour. And then they come around the different fields like medicine, surgery, OBGYN, and we have them for a month. And in that month, I have them for 1 hour. So I have this group of 20 students. I'm going to have them for an hour. And the next month, I'm going to have another 20 students for 1 hour. So I'm wondering, what can I teach them that they might not learn otherwise? Why should I spend my time teaching them? There are 12 cranial nerves, right? The second nerve is the optic nerve. I don't need to, they can learn that from a book. So I try to teach them about language, about thought, about asking questions, about judgment, reasoning. I feel that that's something they might not learn otherwise. And so what I did in this book, the critical thinking book, was I put in all the things I was working on, trying to educate and or illuminate in the past 40 years for medical students to see if something I could have them avoid delusion and learn how to think more deeply than usual. And I wanted to call it 99 Lessons in Critical Thinking for Young Doctors. But again, the editor at Oxford University Press didn't like the last 3 words, so those were removed.
Well, I'm sure that in a way it's very good that I'm sure older doctors will read it with interest as well.
Thank you.
And as the conversations told me, there's much that every one of us could learn reading the book. Thank you for your time. It's been wonderful
Thank you.
talking to you about both your books. Thank you.
Thank you very much.